So welcome everybody. This is a grand occasion. This is the Michigan Radiological Society's very first annual Michigan Radiologicals Medical Student Symposium. So I hear a loud roar out there. You're so loud, I can hear you out my windows. So thank you and welcome. This has been a creation by Rocky and Kate Klein. That's me, and Rocky is our chair of our medical student committee. And we decided we needed to really do something to promote our medical students in our entire state. And so as you can see, he is from Michigan State, working with Michigan State. I work with the University of Michigan, and we have put our maize and blue and green aside to create kind of a brownish color, you know, when you put all those paints together. But that being said, we really have the same goal in mind of promoting our medical students as a whole and promoting also the field of radiology. We also want to thank especially the chair of our Women and Diversity Committee, Shadi Azar, and as well the support of our MRS president, Ralph Lieto. So thank you again. We have no disclosures for this presentation. What we expect is we're going to have 8 to 10 minute student case presentations, and the students have worked hard. The goal was to have them present in a symposium setting in which they can get experience with that situation, as well as they went through the process of submitting their cases. And we did have a selection, and out of approximately 20 submissions, we did have 10 that we have chosen for today's special occasion. That being said, the others were fantastic and definitely worth reviewing as well. So be on the lookout for our upcoming quarterly meetings that we will ask those participants who weren't chosen for today's presentation. They will be asked to present at our future meetings. So let's get started. I would first like to introduce our first medical student case presentation, and that will be by Raymond Sun. So Raymond, go ahead and you can share your screen.
All right, thank you so much for the introduction, Dr. Klein. I was just trying to start my video right here, and I think the host has stopped it. I'm not quite sure if I can. Oh, and I think I can share my screen if here, let me give it a try right now. All right, so can everyone see this?
Yep.
All
Great.
right, sounds good. Okay, so just getting started. Hello, everyone. My name is Raymond Sun. I'm a current M3 applying in diagnostic radiology here at the University of Michigan Medical School. So recently I was able to rotate in the cardiothoracic radiology department here at UMich. It was a fantastic experience. I was able to see a lot of really cool cases. So today I kind of wanted to share this interesting cardiac case with everyone. Kind of ties in some medicine concepts as well as some cool imaging. So without further ado, let's jump into it. So the case I'm going to present today is about a 61-year-old female who is relatively healthy in her life until she was diagnosed with a stage 4 leiomyosarcoma. So briefly, this is a relatively rare neoplasm of the soft tissue. It's usually presenting as a mass in the skin, bone, or connective tissue. And that's exactly how it looked in her case. So it was initially diagnosed in 2015 when her husband was actually kind of talking with her, and then he noticed this like lump over her left shoulder. So they went and got it evaluated, and it was initially treated by surgical resection. She ended up having suspicious lung nodules appear on a surveillance chest x-ray back in 2017. And then in short, she underwent a series of treatments, including radiotherapy and surgical resections. However, her metastatic disease progressed. And in the picture to the right, you can kind of make out, this is one of her interval chest CTs during that time. And you can see bilateral nodules in her right upper lobe and the left upper lobe. And as a result, she began chemotherapy with doxorubicin and ifosfamide in February of 2020. Our story kind of begins 3 months later in May of last year, when she began experiencing some new symptoms of swelling, dyspnea on exertion, and heart racing. Take note that she didn't have any prior cardiac history, but she was seen by cardiology who suspected a case of cardiomyopathy. So in terms of their initial workup, they reviewed several things, such as like her baseline ejection fraction before starting doxorubicin. It was already a little bit low at 44%, and notably she also had some left bundle branch block on EKG. 3 months out, her EF had decreased substantially to 31% while on her chemotherapy regimen. Some of you may already be suspecting that there could have been an association with this decrease in her chemotherapy, especially the doxa, which can be especially cardiotoxic. So given this, cardiology also had the same suspicion, and they decided to hold this drug. And meanwhile, they just ordered some standard labs as workup. However, everything looked pretty normal. The lipid panel was unremarkable, electrolytes were all stable, blood counts were within normal limits, and the BNP was normal at 68, which is especially important because it didn't quite match her clinical picture of this new onset heart failure. So during this time, she also had a chest CT near the time of her cardiology visit, but this was actually done to kind of monitor her pulmonary metastasis. At first glance, the heart looks quite normal in size. There don't appear to be any issues in the pericardium, as you can see on the axial, this one, as well as the sagittal views of the heart. But keep in mind that this is a non-contrast study. It was done to reduce radiation with an initial purpose to surveil her lung nodules. So evaluation of the heart is quite limited. Which brings me to my next question. What tests would be good at evaluating the heart? And to kind of answer that question, a good way to decide this is to look over the ACR appropriateness criteria. Now, for those of you who are unfamiliar with this, it's super easy to use. Basically, it's a set of guidelines outlined by the American College of Radiology that kind of helps providers choose the most appropriate imaging study for a certain clinical indication. It's really developed by experts like across multiple disciplines, not only radiology, so it just kind of gives evidence-based recommendations for what's the best study to choose. So looking at our case, we have a woman coming in with new dyspnea. We suspect that it's a cardiac origin with her decreased EF and a history of the doxorubicin. And when looking at the variants, we can't really exclude anything, including ischemic disease yet from our differential. So this chart kind of accurately describes our patient. So let's take a look at a few studies. Studies that receive higher ratings like 9 or more are more likely to be appropriate than tests with lower ratings. So in here, the chest x-ray looks pretty good, but it probably wouldn't tell us more than what we know from the chest CT that was ordered already. We see echo up there, but which was already ordered, and that's how we got our initial ejection fraction. And then a SPECT scan is basically like this nuclear imaging test that uses a radioactive tracer, highlighting areas of cardiac perfusion during rest and stress. And the rest of the studies below, like the cardiac MRI and the PET scans, have a rating of 8 or below. So these are still like really good options, but they don't usually beat out the ones above. So the nuclear medicine SPECT scan is exactly what cardiology ordered next. I won't go too in depth with the findings, but basically they noticed a significant perfusion defect in the territory of both the LCA and the RCA. So parts of the anterior and inferior heart, as well as the interventricular septum, weren't perfusing appropriately. And so when this pattern is seen, we usually suspect that there's some kind of ischemic component, like the arteries are being blocked off. And in the context of our left bundle branch block, they were kind of scared for some ischemia. So they did a left heart cath to evaluate the coronary arteries further. However, that actually showed that the coronary arteries are all patent and all normal, and she had no signs of obstructive coronary artery disease. But so far, echo, SPECT scans, as well as the left heart cath all failed to give a clear picture of what's happening. In the next few months, the patient had another chest CT for kind of monitoring of her metastatic disease, this time with contrast. And as you can see here, the contrast allows us to more easily make out the chambers of the heart, as well as some of the surrounding vasculature in the mediastinum. So in this particular slice on axial imaging, we can make out the LV and the RV fairly easily. Here's the descending aorta, here's both sides of the lungs. Interestingly enough, there appears to be a slight thickening in the interventricular septum. I've circled this area in red. And given her history of malignant sarcoma, this was felt to be concerning for metastatic disease. The chambers of the heart otherwise look pretty unremarkable with the study, but we need some more information about the tissue of the heart itself. So it's kind of time for cardiac MRI. With the cardiac MRI, the story finally became a little bit clearer. In cardiac MR, first cine imaging will be performed. These are basically like movies of the heart while it's beating. And as you might expect, they're very exceptional at giving information on the function of the heart. So on the left is a cine 4-chamber view of the heart. The image on the right is a short axis cine image and is taken at the mid-ventricular level. You can kind of tell the left from the right ventricles by the wall thickness, with the left ventricular wall being thicker than the right. And interestingly, just as an aside, if you look closely at the short axis image, I think you can make out the left bundle branch block that was mentioned on EKG. So you'll see the right ventricle beat, and then a little bit afterwards, the left side goes shortly afterwards. So already on these images, the finding on CT is confirmed that there's some signal attenuation suggestive of a mass along the anterior septum and the interior wall of the left ventricle that's sort of kind of bowing into the right ventricle. And these structures are just kind of the papillary muscles of the heart. So next, after descending imaging, different sequences are obtained to usually further characterize the tissue of the heart. On the left is a T1 weighted sequence obtained with a special technique called dark blood imaging that usually makes the blood black by nullifying the signal within it. And essentially, this technique helps you differentiate the blood from the myocardium, which you can make out at a slightly lower intensity. As you can see on the image, you can make out the mass, which is mostly isointense to the surrounding myocardium. Although it's somewhat heterogeneous. The image on the right is from a T2 weighted sequence. Here, the lesion has some kind of specks of bright hyperintensity, suggestive of some edema and fluid within the mass itself. And so again, we use these initial two sequences to help characterize the tissue better and get some localization. And then finally, after the initial T1 and T2 weighted images are performed, we administer contrast for some additional sequences. So the left picture is a T1 weighted fat saturation image that's taken usually 3 minutes after contrast is given. So here in this picture, you can make out the subcutaneous fat as well as some of the tissues that are nice and dark. And interestingly, the mass is actually very difficult to see here because its enhancement is similar in intensity to the contrast of the ventricular cavities. And then finally, after the initial post-contrast imaging seen on the left, a second set of post-contrast images are performed about 10 minutes after contrast is given. So this kind of delay allows contrast to wash out a bit from the myocardium and the heart, but in certain pathologies like myocardial infarction, tumors, fibrosis, or amyloidosis, that contrast will actually remain. So thus on this short axis image, we can see that the mass is holding on to that contrast, and we'll still see some enhancement while the myocardium is inverted and appears black right here. So given the characteristics of the mass on the prior T1 and the T2 weighted images, as well as these images here, the heterogeneous enhancement, these findings were quite characteristic of neoplasms to the heart. And in our case, this mass was seen on MRI and CT with contrast, but it wasn't identifiable on echocardiography, which, as you may remember, has a score of 9 in the ACR appropriateness criteria. So I think it goes to show that although echo has its benefits, it has limitations. It's often operator dependent and can sometimes have poor acoustic windows. And interestingly enough, I think because of the unique position of the mass, kind of in this interior and apical portion of the interventricular septum, the echo wasn't actually able to distinguish this from just basically motion artifact. So just kind of diving into some discussion about neoplasms of the heart, metastatic disease to the heart is usually way more common than primary cardiac tumors. And in fact, one study cited that it was about 20 to 40 times more frequent. Of the cancers that do metastasize to the heart, things like bronchogenic carcinoma, melanoma, and lymphoma are a little more common, while sarcomas such as this case only make out about 15%. These mets can really affect all parts of the heart, and in terms of symptoms, can cause like a wide range of presentations, depending on what the size of the tumor is and where it lands. So for example, if it lands in the ventricles, then it can cause symptoms that look like hypertrophic or restrictive cardiomyopathy. If it lands in the valves, it can mimic a stenotic valvulopathy, and so on and so forth. So kind of lastly, what about doxorubicin? Was there this component of chemotherapy-induced heart failure, or was it all due to that developing MET? And I kind of find myself asking this question after the case because, after all, cardiology stopped the doxo because they didn't realize a MET was growing in the heart. And I think the answer is maybe. It's really hard to know. When her doxo was paused, her EF did improve, but this is only 6%, and it might be within an acceptable range of variation for the test. Additionally, she was also started on medical management during this time with medications like lisinopril and Coreg, which could have also bumped up her EF. So here I just kind of have some tidbits about usual doxorubicin cardiomyopathy. The things I just want to take away are usually in terms of chronicity, it's a very acute presentation. It happens within 2 to 3 days of receiving the chemotherapy, whereas her case, she kind of came in with these symptoms after 3 months. Again, there's a dose-dependent relation with doxorubicin where we worry about cardiotoxicity at 500 to 550 milligrams of total dose. Again, she only had 300 milligrams of total dose. Also with doxocardiomyopathy, you would expect an elevated BNP. However, she had the signs of heart failure, but normal labs otherwise. So that's basically it. Thanks again for letting me share. I wanted to say a quick thank you to Dr. Klein and Dr. Sands, as well as the Michigan Radiological Society, and I appreciate your attention.
Thank you so much, Raymond. That was excellent. I think what I'll try to do is only have, instead of doing a Q&A at the end, just allow for a 2-minute Q&A right after each presentation. Does anybody have any quick questions for Raymond? I have Dr. Andrea Moore. Excellent presentation. Thank you, Andrea. All right, no questions, and let's go on to our next presenter. That would be Aiden Harris.
Okay. So let me see if I can share my screen just to get everything set up. All right,
Great.
can you see that?
Yep.
Perfect. All right. So before I begin my presentation, I just want to give a quick introduction for myself. My name is Aiden Harris. I'm a third-year osteopathic medical student at Michigan State College of Osteopathic Medicine. I'm a base student at Metro Health University of Michigan Health Hospital, all in the Grand Rapids side of the state. And I just want to give a big thanks towards Dr. Kyle Pfeiffer, MD, who helped me tremendously in creating this interesting thoracic case presentation. So with that, we can jump right in if it wants to advance. All right, so it all begins with the presentation. We have a 70-year-old man who presented to the emergency department with a chief complaint of chronic non-productive cough that is increasing in severity with associated bouts of hemoptysis for the past 5 months. He states that the number of episodes and amount of blood per coughing bout has increased significantly in the past month, and he notably has had increased fatigue and weight loss for the past year. After you started to build a little bit more rapport with him, he disclosed a little bit more information about what's been really going on. And he's been having these episodes that occur at least 3 days out of every week for approximately 10 coughing bouts per day. Every coughing bout gives up about 1 tablespoon of bright red blood with small clots and mixed fluid per episode. And then in terms of the weight loss, he's been having actually 20 pounds of unintentional weight loss in the last 3 weeks. I'm sorry, 3 months. So just to get a little bit more background history of who he is, he has obstructive sleep apnea, GERD, chronic bronchitis, and chronic granulomatous disease. Now, notably, he did have 2 negative TB, PPD skin checks in the past and no recent travel or known recent exposure. And the etiology of the chronic granulomatous disease was still being elucidated by his rheumatologist. So at the time of presentation, we did not have a true reason as to why he had this chronic granulomatous disease, but we did have his pertinent social history. And with that, he was a prior cigarette smoker, about 12 years with about 1/4 of a pack per day. He still was drinking pretty heavily with 8 to 10 ounces of whiskey per day for quote unquote years. And then in terms of his occupational exposure, he was actually a tool and die maker, which exposed him to asbestos through brake liners. So with that, we moved on to his physical exam. We see that generally across the board, his vitals are relatively normal outside of a slight hypertension going on there. But in terms of his cardiology exam, stone cold normal. In terms of pulmonology and chest, he was almost normal outside of the fact that he did have some rales and bilateral expiratory rhonchi noted. So given all this information and the general picture, what imaging modalities would you all order if you had to better assist you in developing that differential? So we chose to do just the basic chest x-ray and CT chest. Unfortunately, I was not able to get the chest x-ray images, but we were able to go in the past and find his original, find some prior CT scans from 6 months prior to all this symptomatology. And this is the CT scan. As you can see, the chronic granulomatous disease is pretty extensive, and he has peribronchial deposits. And then for all of you who didn't really see it, there's a key image. You want to notice that it is just a butt to that bronchial lumen in the 6 months prior CT scan. So now fast forward to the current presentation, and we got the new CT scan, and we want to compare the two. As you can see, it's still pretty extensive, but we have some additional findings. For those of you who didn't see, the positive arrow sign shows us that that calcium deposit is now moved from the periadjacent to directly inside of the bronchial lumen. So given this information in this presentation, there are specific diseases that could be on your differential. Me personally, I was kind of awestruck by this presentation, so I didn't have that great of a differential. So I just wanted to treat this as a teaching point to give you all something if you were to ever see this in the future. So there are some certain diseases that you should be keeping on your radar. There's the primary endobronchial infection, which is essentially just a fungus ball that leads to blockage of the airway and ultimately calcifies. It usually appears with a scattered small nodules along the periphery of the lesion, and in more extensive process, the calcification can involve the entire mycetoma. When the central cartilaginous core does exist, it can be hard to differentiate the two differentiate the mycetoma from a bronchiolith. And a key finding in the history that will help you differentiate the two will be the inclusion of a history of TB. And then moving on, we have the calcified endobronchial tumor, which is essentially just a carcinoid tumor that has undergone calcification. The calcification is more likely seen in the central tumors compared to a peripheral tumor. And then we have the hypertrophied bronchial artery with intraluminal protrusion, which occurs when you have a bronchial artery that becomes enlarged based on a multitude of pulmonic diseases, essentially just a compensatory mechanism to better withstand those stresses. And when you look at the hypertrophied arteries on contrast enhanced CT, you can sometimes note that the bronchial lumen is being protruded into by those arteries. And then lastly, we have the bronchial lithiasis, which is just as simple as it sounds. It's a blockage of the bronchial lumen with a calcified stone. So given the known position of the calcium deposit being within the lumen, what diagnostic therapeutic modalities would best benefit this patient? Bronchoscopy. And with that, these are the actual intra-op images that were obtained from this patient. On figure 1, we note that the bronchial lift is actually directly visualized and that it's obstructing the right main stem, and we have copious amounts of the mucopurulent discharge that's around and just distal to the stone. In figure 2, some of that mucopurulent discharge was actually suctioned away, so you can clearly see it. And then figure 3 is the unfortunate reality that happens a lot of the time. With multiple attempts, it was to try to dislodge it. It was actually led to further engagement. So they had to bring out the big guns and use the rat tooth forceps right here. And it successfully removed and obtained the bronchial lift from that right main stem. Post-bronchial lift extraction, there was no further active bleeding noted, and largely his symptomatology resolved. There were some things that still needed to be addressed in terms of his overarching chronic granulomatous disease, but in terms of his current symptomatology of the hemoptysis and the increased bouts of coughing, that largely resolved, which was a positive for him. So in general, the final diagnosis was the bronchial lithiasis, the chronic calcium deposit that blocks the lumen. So some important information that will help you actually come to this diagnosis is that it is most commonly seen in the individuals who have just chronic calcified lymph nodes that can either erode into the adjacent bronchi, or you can have the expiration of the small calcium deposits with the chronic cough, and then inhale and have the calcium deposit are lodged that way. So it's 2 different pathways that can lead to the same presentation. And then, as you can imagine, with that, the amount of negative things that need to happen in a row to ultimately lead to the presentation, it is a relatively rare clinical presentation, which is why I felt it would be a pretty cool one to present to you all. And then with patients afflicted with chronic granulomatous disease, regardless of the etiology, including like histoplasmosis, the mediastinal granuloma, fibrosis, mediastinus, and sarcoidosis, they can all essentially can lead to this type of presentation if things were to go wrong. And then in terms of the prognosis, it depends on the severity of the disease, and the management options can range from simple observation if the individual is asymptomatic. You really don't want to lead to unnecessary risks. And then if the patient is symptomatic, you can do what the individuals in this case did and go for the bronchoscopy for surgical resection. In general, despite the potential for the major complications, the overall disease prognosis is good if timely and appropriate management is provided. And with that, that's my presentation. I just want to thank you all for the attention, and I hope you enjoyed it. These are my references and sources, and yeah.
Thank you, Aiden. I'm sorry I mispronounced your name at the beginning. That was a wonderful presentation. Our next presentation is by Austin Moss. Is Austin available to share his screen?
I am here. Let's see here. Aiden, is that how you say it? Can you stop sharing your screen for a second?
There you go. It's all you.
Thanks.
Okay. Teamwork, nice.
All right. So hi, everyone. My name's Austin. I'm a rising fourth-year medical student at the University of Michigan. Today, I'm going to present an interventional radiology case. I really wanted this to serve as an introduction to IR for students out there who haven't been able to work with IR or don't really know what they do. I want this also to be an introduction of intravascular techniques and imaging. So for our patient, she's a 32-year-old female. She's got no significant past medical history. She presents to the ED with a one-day history of left leg swelling. She has no, for medication, she takes oral contraceptives. She has no family history of thrombophilia or DVT. As far as social history, she's never been a smoker. And then her labs are just notable for a D-dimer 1100. She has no prior imaging. On physical exam, we see that she has left leg swelling up to the hip with 3+ pitting edema. Her feet are warm, well perfused with pulses palpable bilaterally. Here's just a picture of her leg. You can see here that their left leg is literally twice the size of her right leg all the way up to the hip. So first things first, what imaging should we order to work up this left lower extremity swelling? I think most of us in the audience are probably suspecting a DVT, and that's what I did. So I went to the ACR appropriateness guidelines, and you can see here that for DVTs, we're going to get an ultrasound Doppler, and that's exactly what we did. On this imaging, you can see here, this is the left femoral vein. When we try to compress the vein, there's no compression, which is diagnostic of DVT. We followed the left femoral vein up to the hip, and we could not find the proximal end of the DVT. So to further evaluate, we got a CT venography shown here. Just to orient us, this is our aorta here with our right common iliac artery, left common iliac artery. Here's our left common iliac vein. As I scroll through the CT, you can see the IVC come into view. And you have your right common iliac vein, your left common iliac vein. And here in the left common iliac vein, we have a decreased density compared to the right common iliac vein, which is our DVT. And if you look closely, you can see that it really goes up to the area where the right common iliac artery crosses the left common iliac vein. So this CT, along with her symptoms and the area of DVT involved, is diagnostic for May-Thurner syndrome. May-Thurner syndrome is an anatomic variant that causes compression of the left common iliac vein by the right common iliac artery, typically over a lumbar vertebrae. This disease occurs in really 3 stages. First, you have a chronic asymptomatic stage where the left common iliac vein is compressed. Over time, that compression causes damage to the endothelium within the vein, and it causes this formation of venous spurs. And those venous spurs then act as a nidus for thrombus formation and end up causing DVT and eventual presentation. This is actually a really common anatomical variant. Based on autopsy studies, it's up to 1/3 of the population. However, the majority of people who have this are asymptomatic. It causes about up to 5% of DVTs, and it's more commonly causing DVTs in females than males. So the next question is, what are we going to do with this DVT? If you dig further on ACR's website, you can find appropriateness criteria for radiologic intervention. And this is specifically for DVTs of the lower extremity. And this table is for acute iliofemoral DVTs that are symptoms that are for less than 14 days. And there's really 2 great options we can do. We can anticoagulate alone, or we can do catheter-directed thrombolysis or percutaneous mechanical thrombectomy with or without stent placement. If you actually read further into the guidelines, there's a paragraph about patients with underlying anatomic compression, and that we should have that addressed in order to keep her from developing DVTs in the future. So a consult was placed to IR. Once in the IR suite, we gained intravenous access through the left popliteal vein using the Seldinger technique. We advanced a guide wire up from the left popliteal vein into the IVC past all the area of thrombus. And then we injected contrast near the popliteal sheath, and we watched the contrast over time flow to the IVC. Here you can see that there's a lot of contrast felling defects in the femoral vein all the way up into the IVC. So just to further assess what's kind of going on within the vasculature, we did intravascular ultrasound, which is done with an ultrasound probe that goes in over our guide wire. Here, this little bronze colored thing is our ultrasound probe, and it takes an image 360 degrees around. Here's a video of us. We are now in the IVC, and we pull back towards the popliteal vein. If you haven't seen this, it's gonna be a little disorienting. So here I just have an annotated image of this. And again, we're starting at the bifurcation of the IVC in the left common iliac vein. As we pull the ultrasound probe back, you can see the right common iliac artery crossing over the vein, compressing, and then you can see the lumen open up with thrombus within the lumen here. So after we take our ultrasound images, we remove the ultrasound probe and we advance an angiojet catheter into the area of thrombus. From there, we infuse TPA for 30 minutes into the clot just to break it up. And then an expandable stent is brought up to the area of compression and is planted there. And we do a final venogram, and you can see that the flow here from the left popliteal vein is much, oh, you guys can't see the flow, but it looks more patent. There's no areas of thrombosis like there was before. If you were to watch this in live fluoroscopy, it would flow much better than it did previously. And then this is just a follow-up picture she sent us 2 or 3 days later after the procedure, and you can see complete resolution of her symptoms in a very short time period. It's a very satisfying case to be a part of. So thanks everyone, thanks MRS, I appreciate your time.
Thank you very much, Austin. That was, I love seeing the pre and the post and how satisfying that is to show that we're not just diagnostic, but we're therapeutic as well. So thanks again. Our next presenter is Joshua Volan, and I know he's here because he's one of the few that laughed at my joke. So.
Yes, I am here. One moment, and I'll share my screen. All right, can everyone see my screen here?
Yep, it looks great.
All right, great. So, hello, my name is Josh Volan. I'm a third-year medical student at OUWB here out in Royal Oak, Michigan. I'm planning on applying diagnostic radiology here next year. I worked on this project with Dr. Al-Khatib. He's a body imager at Beaumont Hospital in the Department of Diagnostic Radiology and Molecular Imaging. So today we're going to be presenting an interesting thoracic case. So back in late 2019, a 19-year-old male presented to the emergency department. His initial presentation, he was complaining of nausea and vomiting. This had been going on for about 8 days, and he had some occasional hemoptysis with it. He also complained of productive cough, shortness of breath, and some pleuritic chest pain. And then he also talked about how he had a fever up with a Tmax of 102, but that's resolved now. And then he also talked about how he had about a 13-pound weight loss over the past month. His past medical history was significant for chlamydia that was gonorrhea negative, treated with a Zithro, and he completed that course. As far as the surgical history, that was negative. He's a young guy, hadn't had any surgery yet. And then a family history was non-existent. No personal history or family history of lung disease. And then his past social history was significant for the fact that he was basically a really heavy vape user, 50 to 60 puffs a day. He had just quit though 2 months ago after 2 to 3 years of use. And then he also had a recent exposure to chickens 2 months ago, helping his mom in Atlanta with her chickens, but otherwise had no more exposure to birds. And then he's also had some significant exposure to fiberglass, dust, and debris because he's recently redoing his home. So some construction there. On physical exam, he had mild hypotension, but otherwise he was basically within normal limits. He was satting well on room air at 95%. One thing that was significant was his BMI. And he looked it on his general exam. He looked emaciated, and the only other significant exam findings were his lungs, which had bilateral crackles and decreased breath sounds. So his labs that we got for him were a CBC, which showed some thrombocytosis, leukocytosis with neutrophilia, not leukopenia, and eosinophilia. So we also got a D-dimer on him, which was elevated. And then we did an infectious workup, including HIV, RPR, respiratory atypicals and viral panels. And then we also did some fungal panels, and then Legionella and streptococcal. All of those came back negative. So when he originally came into the emergency department, he got a chest x-ray, and we'll look at that as well. But he wasn't really progressing clinically. So 5 days later, he also got a CTPA. We were concerned for malignancy, as well. He had an elevated D-dimer, leukocytosis, and then this weight loss. So the first image we have here is a chest x-ray. It's in the AP view. And what you can see I don't know if you can see my mouse exactly, but right here, you can sort of see some diffuse interstitial infiltrates bilaterally here in the middle and lower lobes. And I tried to highlight those for y'all. And then here is his CTPA. This is a coronal view. And again, what you can see is sort of some consolidation, leading edges of consolidation, as well as ground glass opacities here. And then you can also make out some, maybe some slight pleural effusions, very trace though. And then again, it's hard to see on these images, but there could be some segmental thickening as well. So here's an axial image. And again, there's bilateral ground glass opacities. You can see that the vessels are still, you can still visualize them. And that's what makes out ground glass opacities versus these consolidations in the posterior lobe here. And then again, this leading edges of consolidation with some peripheral sparing around these edges here. Here's a little bit lower down in the mediastinum. You can again see some consolidations and ground glass opacities. So again, this is just a summary of those findings that we found on that CTPA. So at this point, we were considering multiple differentials. The top of our list was electronic vaporizer associated lung injury. It presents like a lot of atypical pneumonias, but it's basically a diagnosis of exclusion after you've excluded infection after finding all these imaging and clinical findings, And then diffuse alveolar damage was second on our differential. It's a stereotypical response to lung injury with intraalveolar exudates. These exudates can progress to an organizing pneumonia, and then eventually can lead to catastrophic fibrosis. You can also, in this case, potentially see some cryptogenic organizing pneumonia, which is a form of idiopathic interstitial lung disease. It can also be caused by something else, similar like E-valley. It can be caused by E-valley, and often appears midlife and presents with flu-like symptoms, and can also result in fibrosis, but sometimes it also can completely resolve. And then we also are considering hypersensitivity pneumonitis, which is a type 3 or type 4 hypersensitivity reaction. It's part of the reason we asked him about any exposure to birds, because it's associated with farmers or bird fanciers' lung. And then finally, lipoid pneumonitis. It can be caused by mineral oils or fat embolisms. It leads to a similar presentation as a bacterial pneumonia, and this is why it's the lowest on our differential. So when we put it all back together for this 19-year-old gentleman, he came in with pleuritic chest pains, hemoptysis, productive cough, and a shortness of breath with a recent history of e-cigarette use. He had a negative family history for lung disease. On pertinent physical exam findings, we found that he had crackles and decreased breath sound bilaterally without a fever on presentation. He didn't have any leg swelling as well on presentation. His lab showed leukocytosis, thrombocytosis, and eosinophilia with a negative infectious workup. On imaging, we found these bilateral ground glass opacities on chest x-ray and CT. And I want to show you, this is what he looked like at presentation. And then this is what he looked like at follow-up 6 weeks later. It's pretty incredible, the resolution there, how much better his lungs look compared to that presentation. So his clinical course, he was started on antibiotics and steroids. And after 5 days, basically, in the negative infectious workup, they stopped the antibiotics and kept the steroids going. He never needed oxygen while he was inpatient, so they never ended up doing a bronchoscopy on him. And then he was discharged after basically 5 days. And then at 6 weeks, again, just those images were taken showing complete resolution. So this led to the diagnosis of a valley. This is defined as lung injury associated with e-cigarette use within the past 90 days of symptom onset without an alternative explanation. As of 2020, there's only been 2,578 patients in the USA with EVALI and 68 reported deaths. We still don't really understand what causes EVALI, but when you look at the actual lungs on autopsy, there's bronchiolocentric acute fibrinous pneumonitis. And the treatment is usually steroids as well as supportive measures. The prognosis is 96% of these patients require hospitalization. They usually don't. This gentleman did not feel well, and that's why he presented, but the mortality rate is only 3%. It's still out there whether or not you completely recover your pulmonary function. After this, there just haven't been enough cases to provide like a conclusive, idea of whether or not they're able to recover. Other important information that I just wanted to talk about was that 82% of these patients who experience EVALI use THC containing e-cigarettes. 33% of them, in fact, use solely THC containing cigarettes. So not just tobacco, e-cigs do this. Additionally, vitamin E acetate, which is what people basically fill up their e-cigarettes with, has been shown to be associated with this as well. So it's not just the THC or the nicotine, it could potentially also be the vitamin E acetate. And then not surprisingly, people who are getting their e-cigarette juice from family or friends have a higher occurrence of EVALI as compared to people who actually buy from legitimate sources. And current guidelines recommend that pregnant women, youth, or young adults never use e-cigarettes. So this is not an okay alternative to other forms of nicotine or tobacco. So that concludes my presentation for EVALI. Here's some references. I want to thank the MRS for having me on and for everyone's time today. And I can stop sharing.
Thank you. And what a lovely name, EVALI, for a bad disease. So our next speaker is Gabe Walker.
Right, I will get set up here. And for the record, Dr. Klein, I enjoyed your joke too.
Thank you.
All right, just a quick check. Can you see okay?
Yep.
Okay, awesome. So hi all, my name is Gabe Walker. I am a rising fourth year medical student at University of Michigan as well. And I will be applying to diagnostic radiology this upcoming cycle. I first wanted to say thank you, honored to be here to present a case. So thank you for having me. I have a neuroradiology case to present. It's a case that means a lot to me because this was actually one of my own patients that I had during my clinical year while I was on my neurology clerkship. In terms of the radiology findings, they aren't very subtle. They're pretty obvious, as you'll come to find out. But again, this was a patient that I got to help work up from the beginning with very memorable imaging findings. So I'll jump in. My mentor was Dr. John Kim, who helped me with this presentation. So in terms of the history, this was a 65-year-old woman who reported having some changes to her vision. She also reported having some difficulty with word finding, and her husband noted that she was starting to slur her speech recently. And initially, the resident and I got the sense that the symptoms were occurring along sort of a more acute timeline. And in terms of the physical exam, right upon seeing this patient, you could notice this obvious right-sided facial droop. She also had some right-sided weakness as we were going through testing. Just a few that I pointed out. She had some right-sided pronator drift and some satelliting around her right extremity. And then she had this remarkable right homonymous hemianopsia. And that is sort of one of the physical exam findings that you learn about as a medical student, but seeing it in practice is quite a different experience. She had absolutely no perception of what was happening in her right visual fields. And so the obvious initial concern was stroke. And so this patient underwent a stroke protocol, which is why neurology was consulted. And so in terms of the imaging to order, as many of you know, you would start with getting a non-contrast CT of the head. I just wanted to, like many of the presenters, bring up the ACR appropriateness criteria, just kind of highlighting that CT head without contrast for new focal neurological defect, fixed or worsening. On the left is less than 6 hours, and on the right is longer than 6 hours, but essentially suspecting stroke, CT head without contrast is the way to go. And so here is the CT non-con of the head. And so in terms of this patient, as many of you know, the reason to get the CT non-con when suspecting stroke is to look for any signs of hemorrhage before considering an ischemic etiology. And for hemorrhage, you'd be looking for hyper attenuating areas within the parenchyma, which we're not seeing in this case. Scrolling through this patient's head CT, you get a sense of asymmetry that's pretty clear. And then you get this large, somewhat well circumscribed heterogeneous hypoattenuating lesion here in the left hemisphere. It's kind of located in the basal ganglia region with some suspected expansion into the temporal and frontal lobes as well. These right images, I just wanted to sort of give you a sense of the mass effect that this lesion was having. You can see some left lateral ventricle effacement in this top image here, and then I drew a straight line here to hopefully you can get a sense of some rightward midline shift that the mass is causing. And so concern at this point was that there was a brain mass in this patient. So these are the findings that I described already. So it was interesting in talking to this patient further and teasing out the chronicity of her symptoms. Her presentation actually had much more of a subacute to chronic timeline, which was consistent with the findings from her CT. And given the patient's age, the size and location of the mass, the top two on the differential were either were glioblastoma and metastasis to the brain from somewhere else in the body. Other considerations were other brain masses, including oligodendroglioma or an ependymoma, which were possible. And then in the right clinical context, if this patient was presenting with infectious symptoms, you would consider abscess as well. And so at this point, the next appropriate imaging to get would be a brain MR. And so that was gotten for this patient. I wanted to start by showing the diffusion weighted image as a reminder that ischemic stroke would show up as high signal, and you would want to make sure to correlate that with low signal on the ADC map in order for there to be true fluid restriction present. In this case, we saw low signal on the diffusion weighted image here in the area of concern. And so the big sort of main series to look at in this case was a T1 post-contrast image showing a large heterogeneously enhancing mass in the left basal ganglion temporal lobe here. You get a sense that it's lobulated as well. There are some areas within the mass that are not enhancing, representing necrotic centers. And so here's a coronal reformat. There was this interesting lesion that was hard to sort of make the distinction whether it was within the left lateral ventricle itself or it's kind of abutting the lateral ventricle. But either way, it could represent a satellite lesion from the main mass here or some sort of metastasis via spread of the CSF fluid. And then I brought up the T2 flare image here, getting again a sense for the mass and the edema kind of surrounding the mass, and then a perfusion scan showing the high vascularity of the lesion. So these are the findings, about a 5 by 4 by 4 centimeter mass here. And so next steps were to get a biopsy of the tissue. And so that's what was done. Her brain biopsy was performed and pathology came back as a WHO grade 4 glioblastoma. Her case was subsequently discussed at brain tumor board, and unfortunately her tumor was deemed unresectable. And so her options at this point were either some combination of chemotherapy and radiation therapy versus just doing supportive measures. And she ended up choosing the radiation therapy and concurrent chemotherapy. I've just been kind of following her chart just because I've been interested in her case. And unfortunately, her most recent note talked about transitioning to hospice care. So, not a very happy ending, but kind of points to the devastation of this disease. And so I'll talk a little bit about glioblastoma. It's the most common primary brain tumor in adults. Its annual incidence is around 3 per 100,000 persons in the US. There are two types. There's the primary de novo type versus a secondary glioblastoma. And secondary glioblastomas tend to have a little better prognosis. They arise from transformed lower grade gliomas. And in order to classify the type, you have to do genetic testing on the tissue. So you specifically identify the type of isocitrate dehydrogenase gene that the patient has. And in this patient, it was essentially identified as the de novo or primary tumor, which is kind of represents 90% of cases of glioblastoma. Median age at diagnosis is around 62 years old, and median overall survival is at diagnosis is around 10 to 15 months. The only well-known risk factor is ionizing radiation, and most often these masses occur in the cerebrum, so either the frontal temporal or parietal lobes. On imaging, the sort of classic findings you would see is essentially what we saw in this case. You see a ring enhancing mass with necrotic centers on post-contrast 2 unweighted brain MR. And in terms of management, ideally, you would do a maximal safe tumor resection, and if not, some sort of subtotal resection, and then any combination of radiation therapy and chemotherapy. But that's kind of all based on the tumor size, location, and the patient's performance status. And so the role of imaging in this case, so non-contrast CT is an integral part of stroke protocol for ruling out hemorrhagic stroke, as we touched on earlier, and brain MR is the gold standard for detecting and classifying brain tumors. Thought it would be interesting to just kind of be mindful of costs to patient. Certainly imaging can cost different amounts at different institutions and facilities, but Michigan non-con CT without insurance is around $850, about $2,600 for the brain MR with and without contrast. And so just some final take-home points here. So teasing out the chronicity of symptoms in patients can certainly help point you to the right diagnosis. Ischemic infarct should show up as hyperintense on DWI with a corresponding low signal on the ADC map. MR brain with and without contrast is vital to helping classify brain tumors. And the most common brain tumors are METs from other parts of the body, but of primary brain tumors, glioblastoma is the most common. And so that wraps up my time. I just want to say thank you, big thank you to Dr. Klein and Dr. Sands for hosting this, and thank you to MRS, and thank you to all of you for being present and listening. I appreciate it.
Thank you very, very much for your presentation, Gabe. I'd like to introduce our final presentation. I do want to commend everybody on their timely presentations as well. Our next presentation is by Rishika.
All right, I'm just going to pull up my presentation. Okay. Can everyone see my presentation? Just want to double check.
Yep, all set.
Okay, awesome. So I'm Rishika Polisani. I'm a medical student over at Wayne State, just started my 4th year, and I'm going to be applying to radiology this upcoming year. And today I'll be presenting an interesting pediatric case, and I put this together with the help of Dr. Leschide from Henry Ford. All right. And so the history for this patient is pretty brief. He's a preterm infant born at 23 weeks and 2 days, and he was admitted to the NICU for failure to thrive. And so at day 7, his exam revealed a blue tinge abdomen, edema to the bilateral flanks, and an increased abdominal girth by 1 centimeter. And so on the right here is an image of another infant actually that presented with similar findings. And so I just wanted to include this image to kind of give you an idea of how these findings would appear in an infant of this age. And so that same day, due to the findings, abdominal radiograph was obtained. And as you can see here on the right, it showed a gasless abdomen. And so this kind of points towards this finding isn't exactly normal, but it doesn't give us a clear direction of what may be going on with the infant. And then just a couple other things I wanted to point out about this image is that this infant has, as you can see, severe lung disease. The infant has hyperinflation of the lungs and diffuse branching lucencies throughout. And so this is consistent with pulmonary interstitial emphysema, which is a complication of barotrauma and RDS. And this is also commonly seen in preterm infants in the NICU. And so the infant's exam was pretty much stable until day 16. And at this time, he had increased abdominal distension and duskiness that now extended into the groin area. Another abdominal radiograph was obtained, but it didn't really give any new findings. So at this point, we decided to order an ultrasound just to see if we could get a better idea of what may be going on with the bowels. And so the ultrasound actually did provide us a lot of information, and that it showed us that there is diffuse bowel wall ischemia with wall thickening, portal venous gas, and complex free fluid. And so as you can see in this top image right here, just to give you an idea of orientation, this is taken in the transverse plane and of the lower abdomen. And as you can see here, this is the iliac crest, and here's the sacrum. And so these blue arrows are pointing to complex inner loop fluid. And as you can see, it's more echogenic than simple fluid due to debris and inflammation. And this image below is taken in the sagittal plane of the mid-abdomen. And here's the spine, just to orient yourself. And so the red arrow is pointing to echogenic submucosal layer of the bowel, which pretty much points to an acute GI process that's going on. And so these yellow arrows here are also pointing to bowel thickening. And so from those images, that kind of pretty much points us to the diagnosis of necrotizing enterocolitis. So just to recap, some of the features that you would see are complex ascites and a focal fluid collection. And this actually points towards a concern for perforation. And then like how we discussed bowel wall thickening as well, and then absent peristalsis and free air. And so continuing on with this infant at day 16, so the same day we placed a peritoneal drain, and it immediately yielded meconium. And this was a basically confirmed our suspicion of necrotizing enterocolitis. And so a couple of days later, we got an abdominal radiograph. And so you can see here that this is the Penrose drain that was placed. And then up here in the left lower abdomen, you can see some return of intraluminal gas. And so from this point on, we continued to get abdominal radiographs, and it eventually showed return of normal caliber bowel loops with gas. And so the infant actually eventually regained his bowel function, which is actually great news because a lot of these infants don't end up doing so well. And so just some background info on necrotizing enterocolitis. It's a life-threatening disease that commonly occurs in premature infants in the NICU. And the etiology isn't quite understood, but it basically causes damage to the intestinal tract. And the severity can range anywhere from injury to the mucosa all the way to full thickness necrosis and perforation. And the reason why this disease can be pretty scary is because it can initially present with small signs and then rapidly progress all the way to peritonitis and shock. And so diagnosing and treating this disease in a timely manner is really important. And NEC, it can be diagnosed clinically, but a lot of times imaging is obtained to confirm the suspicion. And so plain abdominal radiography is actually the gold standard, but and this can help provide information on the presence, amount, and distribution of gas, but it does have its limitations in that early in the disease course, it can show non-specific findings, and it may not be able to really give a great idea of disease progression. And especially in our infant, where you obtain a supine radiograph, it can be hard to see free air if there's not a lot of it present. And so in this sense, abdominal ultrasound can kind of help fill in those gaps because it can help us characterize abdominal fluid, it can show bowel wall thickening, and give us some more information on peristalsis and intestinal perfusion. And then research also did show that there's 4 signs that were most strongly associated with surgery or death. And these were free air, absent peristalsis, complex ascites, and focal fluid collection. And only one of those signs can actually be seen accurately with plain radiograph, and that is free air. And ultrasound also has the advantage of in that it's like portable, non-invasive, and free of ionizing radiation, but it does have its drawbacks in that it can be user dependent and does take skill to use ultrasound. And it can also not be tolerated in all infants due to the pain that it can cause in terms of pushing on the infant's belly when there's already something going on. And in addition to that, if there's a lot of gas present, it can mess with the imaging quality. And so in conclusion, although radiography is the current gold standard, ultrasound can serve as a useful complementary tool in terms of assessing NEC, but more research will probably need to be done in order to determine the, to better define the role that it can play, and also to determine like when exactly and in which patients that it can be used. And so that wraps up my presentation. So I just want to thank you all for your time, and then thank you to MRS also for putting this together.
Thank you so much, Rashika. That was fantastic. And thank you to all of our presenters today. Again, this is our very first inaugural medical student symposium. I am going to ask all the presenters, panelists, and those that have submitted cases that have joined us today, I see you in the attendee list, to mark down this day in the calendar, because we are going to directly, specifically invite you 7 years from now to review this presentation and have you present your current presentation, just so that you can remember the feeling of being a medical student. And I'd love for you to be able to pay it forward in the future, because I think that you are our future in radiology, and you are very important to our specialty. So thank you again. I'd like everybody just to also look at the chat. If you could please spend 2 minutes, not even, to just fill out a very, very brief evaluation, just so that we can get some data and we can promote this for students in the next upcoming years. So thank you again. I don't know, Rocky has been dealing with gunshot wounds.
Yeah, I'm here. I was just going to say, kind of echo what you said, but I want to thank all the students for their hard work. I thought all your presentations were very professional. Hopefully all our attendees learned something from it. If there are some students as attendees, hopefully you can present in the future as well. This is a CV builder for you. We're doing this on your behalf. And this is, again, we're part of the Michigan Radiology Society, which is the Michigan chapter of ACR. So specifically, this section has been made for the medical students. So to make awareness of radiology for everybody, and also to promote yourselves in radiology if you end up applying, for radiology residencies. So that's all I wanted to say. Dr. Kleino, if you want to say anything else, but
no, I just also want to thank Rocky, working with Rocky and Shannon Sage in putting this together in a hastily fashion. Usually these things take a year to set up, but working together and in a fast-paced fashion, we were able to put this together, and now we're going to make it stick. Every house needs a foundation, and you've got to start there. So that's where I'll finish.
all right, wonderful. Wish everybody a good night then. Thank you.
Thank you.